came back on, I lost a call to them, and the alarm went off, the old alarm. So I was cutting wires and stuff as of about 20 minutes ago because nobody could get out here. So it was pretty loud. So anyway, at least I don't have to hear that today. Of course, after hearing me, you might rather hear that. Can everybody hear me okay? Does everybody hear me all right?
I believe we can hear you great.
Okay, I just want to make sure. All right, let me share my screen. And I've got to go where it said here to the settings. The guy showed me. I want to make sure. Let's see. Optimize for videos. Okay. All right. So let's go to screen one. Okay. And hit share. All right. Does everybody see my screen? Can everybody see it?
Yes, sir.
Yeah.
All right. Okay. All right. Well, I'll start it here. Again, thanks for being here. It's a little hard to do these talks via Zoom. We're used to doing them in person. But what I want to make y'all clear of, just a couple of quick things, is there's going to be another event at the Owensboro Chamber, assuming with COVID. Jonathan Estes, Bryan, Burgess at Houchens is having an event at the Owensboro Chamber of Commerce on September 30th. So if we go pretty fast today and you want more, we'll be able to do it there as well. So I just wanted you to know about that. And again, we come with a good message today. There'll be a little bit of gloom and doom here and there. We don't want you to put the hose in the exhaust pipe or anything yet. But ultimately, it's the ultimate hope. There's 6 opportunities in healthcare. So without further ado, let's get started. If this clicker works, it's not working. That's not good. It's not, my screen froze up on me. All right, there we go. Okay. So I know y'all are busy, no time to hear what we have to say. Well, sometimes it's good not to go to battle right away and maybe hear what someone has to say. So I hope I got your attention with that. We've got a lot of artillery and a lot of great ideas to share with you today. Who are the Mitigate partners? Very quickly, Rich did a good job at the beginning. It's changed a little bit, and it's now 23 firms. I think actually 24. And what we chose to do is like for Jonathan and Bryan, they're very knowledgeable, very cutting edge. But what we learned is no one person has all the answers. And so about a few years ago, we kind of started on this journey, and we believe collaboration over competition is better. And then we try to marry it with local management in the market. So you can see we kind of got a pretty good little map started so far. All of these are independent business owners that we work with. They're all independent agency owners. And what we found is it eliminates the myopic view they might have in their shop by hearing some different input. For example, myself, somebody from Amarillo in Gainesville, Florida, worked on a large city in Florida together successfully. So that's what we try to do here. And we think basically you want to go fast, go alone, want to go far, go together. So we bring the best minds. We just had a big event last week for a couple of hours. We all got together on a Zoom. All right, y'all, if y'all are going to take pictures of the screen, this is one to do. I'm not going to spend much time on it. This is a homework assignment. And if you don't have this book, Jonathan and Bryan can get this to you. And I'd encourage you to get this book and read it. Each chapter stands on its own, so you can skip around and never miss a beat. Very intimate design. It's the Health Rosetta Day Chase, and it's basically a blueprint for purchasing and advising benefit plans. So if you're a purchaser out there, which I assume many of you are, it's a great blueprint. And we were fortunate enough and blessed to be one of the first 30 advisors selected to go through the program, so one of the founding advisors. So that's a great book. This book called Unaccountable by Dr. Marty McCary. He's gotten a lot of acclaim lately with his last new book. Y'all have ever seen the TV show on Fox, The Resident, that is premiered? I think it's on its 3rd season. That is what Unaccountable is, a takeoff on the book. And Dr. McCary is Dinesh in the actual show. So these books are unbelievable. And basically, you can see from the titles, I would encourage you, it changed my advising career. Then another good book is The American Sickness. That's for really geeks like me if you want to drill down. Elizabeth Rosenthal is a great author. She's now the editor of Kaiser Health News, used to be with New York Times. So she's written a bestseller. And another one by David Goldhill. Just great books. If you get a minute, take a picture of the screen and get these books. I'd highly encourage it. That's how we sharpen our craft all the time. Another book that came out that is not for public consumption, but we can get you a copy, was a Rehumanizing Health Plan. This was released in February, and 3 of our Mitigate partners, including yours truly, were featured in here with case studies, which we're glad to share with y'all later. And you're going to see a video about the Gasparilla a little bit later. And then lastly, there's a opioid book, at least there was. My screen is frozen again. Oh no. I apologize, guys. My screen's hourglassing. Give it just a second here. There it goes. All right. Then the other book is The Opioid Crisis, another book by Dave Chase. And if we thought we had an opioid problem in the last few years, we've got a major one now with everything going on with COVID and the mental health struggles that everyone else has in America. I don't know about you guys, but it's very common. We see it in our groups. Another great book. And then the latest book that is about to be released is the COVID wake-up call, Relocalizing Health. The future health is local and open and independent. And again, 3 of our case studies, 3 Mitigate Partners case studies are featured in the book. And the foreword is written by Marilyn Bartlett. She's the one that basically has been voted number 13 in Fortune's most admired world leaders in 2019 for what her work she did in Montana, reforming their whole state health plan. When she came on board, it was headed for a $12 million deficit. When she left, it was $110 million in the positive. So what she did there is legendary. Glad to get you information about that too. And here's some things about the Gasparilla Inn and so forth that you can find. All right. Does your annual renewal meeting look like this? If we don't change anything, maybe something magical happens. Healthcare costs go up, profits go down, the wages stay flat. And there's going to be videos and music, guys. So we like to call this magic. Ho, 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 it's magic. If that's what you guys are hanging on, we can help. We're here to help you today. I can't see if anybody's laughing or not, but normally that generates a laugh. So what if your annual renewal meeting looked like this? This is what's possible. A change will do you good. Costs go down, profits go up, and wages increase. It's absolutely possible. We're going to share with you a couple of examples today of how it's been done around the country. What's in this for you? We're going to pull the curtains back. It's the great reveal and expose how this status quo has been designed intentionally to make your health insurance cost more. We're going to allow you to break free, empower you, and offer 10 times the benefits for half the cost. And by you being able to become an active manager of your health plan, you'll be able to become an active manager, and you'll be able to save your company a lot of dollars, allowing you to put more back into communities and allow employees to save more for retirement. Key themes today: build employer-built care. I'm going to talk about these as we go. So I'm not going to spend a lot of time on it right now. Take active management of your spending patterns instead of relying on the traditional passive managed approach that a lot of our clients used to rely on. We call it the BUCAs. You're going to hear that term today: Blue Cross, United, Cigna, and Humana. That's what we call the BUCAs, to keep it simple. And most of the approaches that they deploy are more of a passive approach. We'll get into that later. Relocalizing the care. We got to get back to neighbors taking care of neighbors. I always say Marcus Welby MD times, and I get a lot of blank stares with the millennials. If any of you young folks, you can Google it and see it. But I grew up with Marcus Welby MD. That's what we're doing in our clients. That's the kind of world they're living in, instead of this decentralized, patients not in the middle and not in touch. That's what we have done with our programs. And let's build community-owned healthcare. It should be Owensboro-owned healthcare, not insurer-owned healthcare. You guys should take control of it. And then maximize a local care team: community pharmacist, physician, hospital patient. All of these individuals, they need to be taking care of the employee and the patient together without any interference. And again, through that, you'll be able to have 10 times the benefits for half the cost. And then you will have health insurance your way and on your terms. That's what we hope to help you achieve. My computer hourglassing again. All right. Sorry. Get that off the screen. Why did that come up? And I need to move this thing. There we go. All right. There we go. All right. Quote of the day: healthcare is not broken, it was made this way. What do I mean by that? healthcare has not evolved like many other industries. Let's take a peek. Anyone know what this is? 1965, the first mainframe computer. Huge deal, took a whole room up. Let's go look at phones to compare. We got a phone, then we had a Palm Pilot, and y'all have a Palm Pilot. We merged those two, and then we got phone and contacts. Then we added email and a web to it. And y'all know what we got out of that, anybody? Named after a fruit, a BlackBerry. Guys, what happened to BlackBerry? It didn't evolve. Where is it now? It has not evolved. Then we had music. Then we brought that in. And we added videos and so forth to it. And then we brought those together. And then we made touch screens. And then all of a sudden, y'all know the end product we get. It could be a Droid or an iPhone. We took the most complicated human invention ever in the history of the world, arguably, and got it into the hands of a 95-year-old grandmother that she can hold. Why can't we do this with healthcare? This is healthcare. It has not evolved, and we're going to talk about that today. So let's set the record straight. Quickly, eliminate payer from your vocabulary. There's no such thing as a payer. People refer to the BUCAs as payers. Insurance companies don't pay claims, folks. Employers and employees pay claims. It's your employees that are paying for healthcare, not the insurance company. They process the claims. They are the processors. And eliminate reimbursement for your vocabulary. How many of y'all offer a service to the general public and you get paid for it? Are you getting reimbursed for the service? Are you getting paid for the service? My father was a 40-year OBGYN in Macon, Georgia. I know y'all thought I was from New York City, but I'm sorry to disappoint you. When he delivered a baby, he got paid, but everyone calls it reimbursement. That's not a reimbursement. You're being paid for the services performed. And take provider from your vocabulary. That's a tough word. It's very cumbersome. It means we like physicians and facilities. And the real next question that we run into all the time is, are you willing to change? This is what we hear all the time. Jonathan Bryan and I get this all the time. We really like what you're doing, Carl and Jonathan Bryan, but, has it ever been done before? Where's the ROI? Well, I'm here to tell you, folks, it's been done a lot. And we're going to talk about that. All it takes is a good advisor and a little courage. This is one of our Mitigate partners in North Carolina. All it takes is a good advisor and a little courage. The courage is you guys. The courage is the courageous employer. That's what this is about. Our job is to help you be courageous, to have your back so you can step out and do something different. That's what we do. And while we want to give you a pat on the back for being courageous, at the same time, a part of me always says, Mount Everest was once unclimbable. Now there's a litter problem. There's literally thousands of oxygen bottles all over the mountain because so many people have climbed it now. And there are people that die every year, of course, but it's been done a lot. And what we're trying to say here is, as courageous as you are, we've got 4 clients in our Fair Cost Health Plan we're going to talk about later, and we've got them all over the country that have done this. So I think the easiest way to look at healthcare is this. Hey, doc, can you see the problem? Patients on the table. I'm afraid so. The third party. The middle people, the middlemen are in the way from the doctors taking care of the patients. And we're going to talk about that, but that's what we really try our best to eliminate is the middles. And you're going to see the results here in a minute. Also, many of you have an ID card that your employees have. And I guarantee you it has a Blue Cross, United Signet, and Humana logo on there. Why are we giving these people all the real estate on our card to free advertise? At least charge them to advertise. They're charging you to access their plans. At least charge them for advertising space. That should have your logo on it. It should be your card. It should be Owensboro Built Healthcare or Southern Star Built Healthcare or Owensboro Health Regional Built Healthcare. That's what it should be. Don't hide behind the BUCA logo. And lastly, if we achieve these things, this is what's important. You get neighborhood health care. And that's what this is about. Eliminating the counterproductive barriers that get in the way of good health care. That's what we're talking about. And letting the hospitals, the physicians, the pharmacists take care of the people. That's what this is about. And I meant to warn y'all, I'm very passionate. So if that's coming across, I'm sorry. We're not here to sell anything. We're just very passionate about what we do. And the results we've gotten have just been unbelievable, and many have received national attention. This hospital video I want to show you real quick. PatientRightsAdvocate.org. Google it. They're the ones behind all the White House, all the transparency stuff you're seeing, all the legislation coming out about hospitals revealing prices and showing their prices. They're all about the transparency movement in healthcare. Healthcare is the only thing we buy without knowing the cost for 30 days. Would you buy a car without knowing the cost? Of course not. And they are the ones behind the movement. Everything you see, they're behind it. They called us last October and said, we heard about what your Mitigate Partners is doing in the state of Florida. Can we come film your clients? We want to share this information with HHS Secretary Alex Azar and the White House. So let me play the video for you, and we'll come back in just a second.
We are self-funded here at this facility and have been for 30 years. Our premiums kept going up and up and up. We're a small 49-bed hospital, and we realized that we've got to do something.
When we met DeSoto Memorial, their health plan spend was about $2.2 million. We just wrapped up the first year, and the spend was around $990,000. So they saved $1.2 million, or 54%.
It's remarkable how much you can discount the price of something if you know you're going to get paid at the time of service.
What do we eliminate? The middle. We're going direct. That's how you save. It's direct employer contracting. We negotiated a cash knee replacement price. That hospital was 70 grand. We got it for 25.
Direct primary care, where you just pay $65 a month, and that covers all of your primary care. And sort of the bundled cash payments are two prongs of things that we can do to actually reduce the cost of health care. We also have a program that's called the Medical Advocacy Program.
They walk you through the process.
It was kind of blowing my mind when they turned around and said, well, we'll do everything for you.
Getting them to the right doctor for the right quality, lastly, the right price, and at the right time. That's what this is about.
The less we have to spend on plan, the more we're able to put back into salaries, back into maybe additional benefits or increasing benefits.
It's medical expense per employee per year. When we met them, it was almost $14,000 per employee per year. It's now right around $6,000.
Biopsy comes back, positive for cancer on the left side, and a week later, I was headed into surgery. As of today, all is well. I have gone through the process, an estimated cost of $42,000. What did I pay? Absolutely nothing.
And there was a lot of cost savings. So I actually got the bill 3 days ago, $31.76. An MRI is thousands of dollars. If something were to happen to me, or God forbid, one of my family members, it's covered.
The opportunity to take this model that DeSoto has can be replicated across the country in all these rural areas. Absolutely.
Not having to sit around that board table this year and say, okay, how much of the increase is going to go to the employees out of their pockets? I was giddy. I was excited that we did not have to do that this year.
And we deserve that. I know I do.
Guys, that's a hospital. It's an employer, but it's a hospital. That's what's able to be achieved. And we're going to talk more about it as we go through here. I'm going to go in a little detail, but what I wanted to tell you is there's several of these videos you can see. We just spoke at the Florida Rural Health August the 14th. They had us come speak and share the case study with our client. I'm glad to get you links to all of this. We're not going to watch it today. Also, we did the DeSoto Memorial story on November 2nd last year from a deer stand, if you can believe that. They asked freetohealthcare.org asked us to do this talk. And I said, I'm going to be hunting. And they go, can you do it? I said, sure. It's 36 degrees, and we got through it in about 10 minutes. Didn't see any deer. They kind of weren't interested after that. But anyway, been done from a deer stand. And then also, Jonathan Estes came to this. Dr. Lee Gross, the direct primary care doctor, will talk about that brought us to the hospital and how we got him as a client. He did this talk. We did this talk November 15th of last year. Again, you can see that on our YouTube channel. We'll get you that for more details, but it's very good. Also, it's featured on Christy Gupton, the one that said all it takes is good advice and will encourage podcast. So it's been everywhere across the country. Real quick, here it is. There are about 157 employees on the plan. It's a 49-bed hospital. Here were the challenges they had. They're the fourth poorest county in Florida. They lost obstetrics in February of 18. Members got to drive an hour for deliveries. The foreign medical spend averaged 79%. That means that 79% of their medical claims are going away from their own hospital to other hospitals. And they don't do everything. They're a small hospital, but they do a lot more. And that was their spend, $2.2 million. The results, we saved them 58% of their stop loss premiums, which is unheard of, $150,000 due to our fair cost program, and we'll get into later. We weaponized their plan design, and they're in the middle of becoming their own PBM, which is possible depending on how your hospital's structured. Not every hospital. I don't know anything about Owensboro Health Regional at this point, but I can tell you it's absolutely possible with certain hospitals. They implemented direct primary care, we'll cover in a few minutes, with Dr. Groves. Hired their first full-time surgeon in county history. Foreign medical spend went to 62%. Huge improvement. Why? We broke all the barriers to care. If they come and take care of themselves in their own hospital, like Hannah did, $42,000, there was no deductible, no out of pocket. Those are the kind of things that we achieve even for companies that aren't hospitals. And that was their spend. And they also got a rate decrease, second ever in the history of the stop loss carrier. Doesn't happen often. And that was the first year savings. So anyway, very quickly, I think it is pretty important. 3 months, we were on a BUCA plan. So we started October 1 of 18. So for 3 months, we're on the BUCA plan. Then 7 months on the fair cost plan, all the way through July of 19. That's how much was spent. It's quite amazing, almost the same amount of dollars over 7 months versus 3 months. And that's active management we're going to cover in a few minutes. And then quickly, the 1 year, you saw this already. I'm going to move quick through this. You already saw that. And that's what they were able to save. This is the current state of health insurance in the country today. We got a system failure. Warren Buffett thoughts. GM is a health and benefits company with an auto company attached. They're not even an automobile manufacturer. He views them as a health and benefits company. And it's the tapeworm that's killing the American economy. And we got to try to do something about it. And it's very difficult to keep the business in the United States, not doing things across the seas, et cetera. And then, as Albert Einstein always says, we can't solve our problems with the same thing that we used when we created them. And that's really what we're going to talk to you about today. So what's the bottom line? Cost equals utilization times price. We're going to talk to you about each of these. Historically, employers and their brokers, so whoever you guys work with for advice, have focused on the wrong things. They focus on the administrative cost, what we call the fixed costs. That's what everybody's asking. Hey, how much do you charge PEPM to administer our health plan? That's really the worst question you can ask. It's just not that important. What's important is the variable cost. These things in healthcare, overcharges, non-compliant charges, the claims is where all the money is. And you want to focus on your top 20%, and that's the variable cost. If we do that, we can still save in the fixed cost area, which is unfortunately all anyone wants to hear about, which is, again, a big mistake. But again, if I'm you, that's what you've always heard, and that's what you've thought. So the perception for you is that. Then we can save here. And I think you already saw examples of 54% savings. All right. Also, we got to be careful, folks, because we're headed into this part right now. We could have a dereliction of fiduciary duties. I'm not here to challenge or scare any of you, but I'm here to tell you we got a real problem. We've got so much regulation on 401k plans, 401k advisors that are giving investment advice that the DOLs are around chasing pennies while tripping over bags of dollars in healthcare. And I will tell you, that's not going to last long because ignorance is not a defense. And I can tell you right now, go Google it. Google Gap employees, the Gap stores at the mall. I think one of the employees had some claim that was not even possible for them to pay. And their premiums kept going up and the benefits got worse and worse every year, like most companies in America. And they said enough's enough. So they sued the HR and the CFO. So again, I'm not here threatening you. I'm just telling you when it falls, it'll be an avalanche. There's all kinds of lawsuits out there right now about this. So we're hopefully here to help you not keep your head in the sand. And unless you're from the state of Florida, and I do not like the Florida Gators. I will make no bones about that. Orange isn't a good color. I know y'all are big blue up there in Kentucky. All right. So what's the bottom line? Only two benchmarks matter. If you said, hey, Carl, you and Jonathan, Bryan, this is great stuff, but I only got 2 minutes. What's the bottom line? Well, this is it. If you ask me to say it quickly, this is it. We can stop this webinar right now. These are the only 2 things that matter. If you ask me how any of our health plans do, this is judge us on this. Everything we do, any wellness plan you do, anything you do will impact those 2 numbers. Do you know what your benchmarks cost are? I've yet to meet anybody that could tell me that on the spot. And that, not knowing that, is like driving a car around without a fuel gauge or a fuel gauge or a speedometer. So here's the per employee per year medical expense. National average is about $12,125. Where's your organization? This is where we kind of hover typically, right in this area. And it's absolutely possible you're going to hear from another company in a minute that's done this. That's where we are. Think about how many employees you have and do the math on that. And it's pretty substantial savings. Prescription drug expense per member per month. Where's your company? We're usually about 44% of the national average is $100 now, and we're usually about 44% under with a fair cost. So I want to talk to you about house real quick and a concept. So think about this real fast with me. Everyone wants to build a house. I want you to think about, well, some people want to build a house. Some people have bad experiences, don't want to ever do it again. But everyone eventually wants to own a home, kind of the American dream. So think about that with me as far as your health plan goes. Think about it like a house. So what we run into a lot, and most all over America, is your traditional passive health plan. Everything's there. It's easy. And we call that BUCA Insure Built. Yeah, you've got to pick your deductible and your out of pocket, but the programs that are picked that are in your plan typically are the BUCAs. And a lot of times they make you use the pharmacy benefit manager, or PBM, or program billing millions, as we like to call it. And if you pull it out and want to use your own, they charge you $2 to $3 to $8 PPM for that. That ought to tell you all you need to know. So anyway, that's BUCA Insure Built Healthcare. And then this is what drove us. We were so frustrated. Your perception, and all the people we meet regularly, they think that their health plans are great. And based on what they've seen and heard, I would agree that all of our clients felt that way. But it was time to change and build something that made the other model obsolete. And that's what we really did with Fair Cost. But again, perception is everything. Is that 3 or 4 boards up there? On the right, is that person looking at you, or is it a side profile? Down the bottom left, is that a vase or 2 people looking at each other? And on the right, how many legs does the elephant have? Perception is everything. And the perception you have, all of you on this call today, is what you know, what you've seen, what you've heard. And it works good, right? We call it insure built versus employer built. So we brought that up earlier. Let's look at Mr. Potato Head. This is an insure built plan, and your perception is things are great. When we come in and start talking to employers, and again, they're here, it's a different story, a whole different way of doing it. That's the easy button, but we feel this is what we run into most of the time. Not a real pretty Mr. Potato Head, and it's time to hit the panic button. So we deconstructed it and unbundled the system piece by piece and rebuilt it into an actively managed plan, picking the best components and best parts. So now we got a human patient-centric plan with all the middleman out of the way. And maybe you don't like Captain America, Mr. Potato Head. Maybe you want something different. The key is it's your plan, so you can do whatever you want to do. It's your choice. So the key, you want Wonder Woman, Mr. Potato Head, or do you want Darth Vader, Mr. Potato Head? I don't know, but it should be your choice. We must go to an employer-built plan. That's how you'll get what you want and do it. Why you should build your own plan? A lot of us rent before we buy, but we know there's advantages to home ownership. Insurance companies build these plans and allow you access. So they're insure-built and they rent access to you. You have your network access fees you pay as part of your plan to access their network. And the data is very hard to get sometimes, the kind of data we like to get. It's a struggle. I've got a large school district, 9,000 belly buttons, and we're having trouble getting data from the BUCAs. It's very difficult. And if it's your data, why? Why can't you? Insurance companies, as we said earlier, don't pay for care. Employers, employees do. If you take anything away from this, no, they're the processors. You're the payers, your employer, you and the employees. Now, a homeowner has input into their home construction. You should have input into your health plan. Why can't you help build it? You get to pick the supplies, the faucets, all the way down the doorknobs and the bricks. And then you start building. So here's what we come up with ultimately. Let's talk about building a plan. And the foundation is direct primary care. I'm going to cover in a few minutes. That's where we start. And then we build it brick by brick. And where this may look daunting and, oh my gosh, there's a lot of stuff there, Carl. We spent 7 years finding the best bricks and the best electrical and the best plumbing to make it easy for you. That's what we did. Most of the BUCA and SureBuilt plans don't have all these bricks in them. These bricks lead to 1.2 million or 54% in savings for that hospital. It's a custom built and actively managed health plan. Again, thinking of it in the house, we think it's a good way to look at it. Now you say, Carl, oh, this is intimidating, that's confusing. We call it employer built again, and it's the Fair Cost Health Plan is one choice you have. You don't have to use that. But this is what's important to your employees. All they want to know where the front door is and how to open the door. And there's a doorknob, and they come in. One call, that's all. They don't need to know what's behind the sheetrock, what electrical, what plumbing. That's all they want to know. So what does your plan look like? For me, I'm a Georgia Bulldog. I like red and black or silver britches. I like the house on the left, more of a Georgian colonial home, simple. Maybe you like the house on the bottom right, it's modern. Maybe you like the one in the middle, it's a mansion. What does your plan look like? It's your choice. Don't let anyone tell you otherwise. So here's an example of our Fair Cost Health Plan that the hotel client that was mentioned in the Dave Chase book has. I want y'all to look at these deductibles, co-pays. I'm just going to reel them out to you. I mean, these programs haven't been around in 30 years. Look at those co-pays or no deductible. You only have to pay a co-pay for the outpatient, inpatient, 100% co-insurance. To hit the out-of-pocket in that plan, you gotta take about 90 drugs and go to the hospital 20 times a year. We've really never had anybody hit the out-of-pocket. It's near impossible. And then they charge $80 to $160 per month for the employee-only rate, including dental and vision. How would y'all like to be able to do that? Absolutely, it's possible. And that's what most of the other health plans in America charge. And then again, the benchmarks, this is where they measured up to what we talked about earlier. We covered that. So now, how does it look in motion? You're going to hear back from Hannah for a minute. I want you to hear what she says. These benefits are for us, not done to us. How many of you out there listening are doing benefits to their employees or the benefits for them? It's a big difference. And hear how she was scared to take care of herself because her deductible and her coinsurance. Now she doesn't have those worries. Very powerful. This one, again, you can go to their website and see them, but I'll play it.
Well, the benefits that we have here at the hospital are more so focused on the employees. The latter part of August, I had a concern regarding my neck, and I went in to see my primary care, listened to my concerns, and he recommended certain protocols. It was my choice of what I wanted to do. You would think with the specialist, the appointments are so far out. Within maybe 3 weeks from seeing my primary care, having my test done, getting my results, finding out that I need to have a biopsy done. Biopsy comes back, positive for cancer on the left side, and a week later, I was headed into surgery. As of today, all is well. I have gone through the process, an estimated cost of $42,000. What did I pay? Absolutely nothing. So before, I was paying all that money on my premium, and I never used the plan because I was reluctant. Because of, okay, I have this copay, I'm going to have this deductible. We don't have those issues. Every concern I've had since day one of this plan, I have addressed and have taken care of this year. And I've paid absolutely nothing out of pocket. And we deserve that. I know I do.
That one always brings chill bumps to me. I know Hannah, and She's a rock star. I don't know how she did those interviews, but that tells it all, folks. That's what's absolutely possible. So the employer journey, before we jump in these 6 opportunities that this was about, you might want to crawl, you might want to fly. A lot of our clients have flown. They've skipped all the steps. But again, this is a plan for you. How do you want to build it? You don't have to start flying out of the gate, but it's a journey. And folks like Jonathan, Bryan, and all of us are there to help people. That's one of the things you can do with that. All right, what can George Costanza teach us about healthcare? I'm a big Seinfeld buff. What can George teach you? There was an episode a long time ago where his life had not worked out great. Every time his intuition told him to do something, he said, it never has worked out. I'm going to do the opposite. So he was in a restaurant in that cafe, and he saw this woman over there, and he went up and says, my name is George. I'm unemployed, live home with my parents. And she says, I'm Victoria, have a seat. And his whole life, he would have never done that. He did it the opposite. So what can you learn from George? Do the opposite. So whatever your broker tells you, do the opposite. Raise your deductible. Raise your out of pocket. No, do the opposite. Go to no deductible. Lower it. Make the benefits better. 10 times the benefits for half the cost. Again, it's totally possible. We're going to cover some more. You already seen a little bit so far. Also, why are we charging the diabetics for test strips and all those things? The diabetics are 10% of your population normally. It's one of the easiest things to fix, and they have more health problems. But once you identify them, give them the free test strips. What we do with our clients is if they go to a community pharmacy once a month, a community pharmacy where they meet with a pharmacist for 15 minutes a month, we synchronize their meds and they get all their test strips and all the medicine for free. Do the opposite. Yeah, it costs you money, but keeping them out of the ER and out of the inpatient admissions is a big deal. All right, path forward. So y'all got to answer this question if you can. You want to stay passive or go active? And since I can't see anybody or hear anybody, I'm going to make the choice for you, because if we don't make the go active choice, and that's the old red pill, blue pill from the Matrix, if you guys recall. So we're going to go active. So here are the precepts we believe in. We just told you this healthcare system's broken. It was made this way on purpose. It isn't broken. These people were geniuses. Insurance companies and hospitals and things have all, and I'm not, guys, please hear me. I'm not saying every hospital, please, but there's some large corporations out there and so forth. And a lot of this is done at the expense of the employer. And the brokerage community, these brokers out there, have passively watched and let the cartel manage the business. Your employees are likewise victims. It's not the employee's fault. They've been conditioned to do it this way. You can't blame them. Trend. I'm sure y'all have all had a trend increase passed on you. Well, Rich, the trend increase is going to be 7% this year because the medical technology and costs are going up. I'm going to talk to you about trend. We don't believe in it. It doesn't exist, and I'm going to cover that a little bit later. Why are you taking trend? Where our clients get rate decreases or stay flat. We don't think there's any trend, and we'll cover that. Richer plans equal less claims. We've covered that. Relocalized care. Get back to the way when healthcare started and it worked. So again, the last 7 years, we spent a lot of research and time and identified these flaws in the system that we've turned into opportunities for you. I hope this is an uplifting message. As you see, I'm very fired up. It's a great opportunity for you. So please listen closely if you can stay with me, and hopefully we keep you entertained. And let's look at that. So again, we've got the resources. We've identified these things. And by active management techniques, you can regain control of your health spending and your employee. And we think the employee experience will improve, as it did for Hannah, as you just saw. So here's what the talk was about. The flaws in the healthcare system. The cartel, I'm going to cover it. Lack of pricing transparency, billing errors, traditional PPO discount game, pharmaceutical shell game, and lack of information and data. Again, positive message, these are your opportunities. Maybe you don't want to build your house by solving all of these. Maybe you want to solve 2 or 3. That's what this is about. Let's cover the cartel. That's my favorite term. Everybody knows me as the cartel guy. All healthcare relationships are incentivized to make your health cost more. and all of them are in a position to make it happen. The only person at the table that wants the cost to go down is the employer and employees. Take a better picture of healthcare in America? Take a close look. Now, please, again, we're not trying to pick on any particular entity here, but if you look behind us, you'll notice out the conference room window, the insurance companies and so forth. The names are all out there. And I also want to be clear, guys, Bryan, and Jonathan were part of the cartel too. I was guilty for a long time until we took a different path 7 years ago. So I'm as much responsible as anyone in this. But look at this, Pete. Who is sitting on the side of your table right now helping? Because everyone's making money and you're having to pay more. So that's the best summation we've seen of it. Now, let's take a peek at the 2019 Fortune 500. I want you to look real close at those in the red box. They're all healthcare companies. Those are PBMs, pharmacy benefit managers, program billing millions. United Healthcare owns its own PBM Optum. So if you've got United Healthcare, I guarantee you got Optum. CVS and Aetna merged. I'm still not clear why the DOJ allowed that. And Express Scripts just merged with Cigna, guys. And the companies that make the drugs, AmerisourceBergen, Cardinal Health, and McKesson, they are the people that sell the drugs to the pharmacies. They're middle people. And the people that make the drugs are lower down the line. How can that be? The people that make them are less. Look where Cigna is, 65. We got a slide coming up in a minute. We're going to show you something that's really powerful. Now, I want to show you this. This is 10 years of salaries and insurance costs for one of our clients. Okay? 10 years, all real numbers. I can tell you later more about it. This is it. In 2010, right before Obamacare came out, Affordable Care Act, whatever term you want to use, that's what the teacher salary was. Their family health cost was that per pay period. Over a 10-year period, they had a 3.85% increase in salary, and the health care costs went up 39%. These folks can't get raises because the health care costs are eating so much out of it. That's how much it meant from a dollar standpoint. That's a problem, folks. I mean, education is the bedrock of our country and our youth. Here's an example of an insurance company during that period of time. We'll look at Cigna in this example. And that was their stock price in 10, a 573% increase, folks. And for a little humor, they just jumped from 65 to 13, 52 spots. So we'll take a look, see what Harry Potter has to say. We got a real problem, and here's just stock prices, and it's outdated, but the multiples, if I had been smart, I'd have bought all these insurance companies a long time ago. It's crazy what's happened on the backs of middle-class America. So that's part of the cartel. So who is advocating for you guys? You're the purchaser. Is it the hospital, the insurance company, and the broker? And again, I want to be clear. I'm not saying all hospitals, guys. DeSoto Memorial, these community hospitals, your community hospital, Owensboro Health, they're great facilities, great hospitals, please. But we've got people going to care other places, and this is a problem. So shouting at everybody doesn't really help. So who's your advocate? So basically, we're left with this: outmatched and outgunned. Unfortunately, this story doesn't work out for most of us, but it certainly did in this movie, but not right now. So the solution is real easy, guys. Eliminate the middles. Get rid of the third parties. You don't need them. It'll make Owensboro Health Regional a lot happier. It'll make your employees a lot happier. And it'll make the physicians taking care of your employees much happier. And it absolutely can be done. Every example you're going to see today, we've done that. All right, so let's go over the first active management opportunity real quick, value-based direct primary care. Let's cover this real quick in the theme of the house. Direct primary care, guys, is a direct contract that a physician has with your employee or your group or your company. It's not a fee-for-service environment. They're sitting there for 30 minutes to an hour with patients taking care of them. It's a fixed per employee per fee. Like Dr. Gross at DeSoto, $65 for employee and $65 for the spouse, $25 for the first kid, $10 for every kid thereafter. Those are the charges. And it's a set fee, so you can go as much as you want to see them. The difference is they can take care of them. My primary care doctor, all they do is refer me to specialists. Thankfully, I'm pretty healthy, but that's all they do. There's no care because they're in a fee-for-service environment. We got to get back to DPC, and it's direct primary care, and it truly is Marcus Welby MD days. And I will show you that's one of the reasons DeSoto saved a lot of money. And this is the other thing. You know, why are we insuring something that costs this much? This infrequent and low cost. Why are we paying for insurance for it? We don't need to. Real quick, I can't cover this, but Dr. Gross took care of 2 members. They were on Percocet for 15 years. I don't think I'm supposed to conduct this webinar on Percocet. These were serious problems. They got them off. We had an opioid problem when we reviewed their data, and you're going to see it later. Within a year of DPC being involved, we ran the numbers again, and the opioid problem was almost non-existent. That's the power of a relationship with a doctor and the patient, unencumbered, nobody in the way, taking care, not calling for pre-cert or prior auth or peer-to-peer reviews, taking care of them. One more homework assignment, another book. If you want to read on direct primary care, we can get this to you. Yours truly was quoted in the beginning saying it's the foundational building block. And then you've heard Christy Gupta's name a couple of times. We helped contribute and offered help when Dr. Purcell wanted to hear. He's a great DPC doctor. The book is excellent. It's a short read. I'd encourage y'all to pick it up if you're not familiar. Lack of pricing transparency. Let's cover this one. That's the next brick. And we're going to talk about it in the form of cost and quality guidance. But what if we bought groceries the way we buy health care? Stop and watch this video.
There are no prices on anything here.
Oh, believe me, some of it's pretty spendy. Whoa, that's really gone up.
Stop. I don't need both, just one or the other. It depends on the price.
Oh, that's called shopping. We don't do that here. Thank you for coming in. Your bill? Your version will be mailed to you in 30 days. Good luck trying to make some sense of it.
Now, I'm sure some of y'all are laughing. If you come on September 30th, when we're up there with Jonathan and Bryan at the Owensboro Chamber, you'll see it's a lot better when we're talking in front of a group of people, we can see them. There's nothing funny about that, folks. That's what we're doing right now. That's what you're doing to your people. Would you go to Ace Hardware and buy paint or a hammer without knowing what it cost? Waiting 30 days to get your bill later? Come on, folks. That doesn't work. That's a problem, but we keep doing it. So it's not funny. How does your network help employees find the best provider? Got a lot of hospitals in the network, but they're sending employees out to have surgeries like gambling. We're going to talk about that. And this is some of what happens back in the back room with these things and how these things are priced. Again, DeSoto Hospital is extremely fair. I know Owensboro is as well. We don't see it as much in those types of places, but we do see it. And the price is right. You know, what is this? The Price is Right show? I mean, come on. So problems of lack of transparency. Networks and plan designs have been obscured, so you don't know what the relationship between cost and price is. Networks offer discounts off an artificial benchmark known as the charge master. We'll get into that a little bit. Employees, once they hit their out-of-pocket or deductible, they don't care. They just go get more and more care, and it costs the employer a ton of money. That's why it's important. And if a hospital claims $40,000, $140,000, employee pays the same out of pocket, but your health plan doesn't pay it. I know all of y'all seen those catastrophic claimant reports. We'll get into one of those a little bit later. So how do we get employees to care? Real simple. Price doesn't equals quality most things in life, not in healthcare. Let's talk about that for a minute. So we've got where do Owensboro employees go for care? This is what's called a DRG. Just think about it as a hip and knee replacement. we were doing some research, and again, none of it's perfect, but we have access to tools and resources. So where's this employee who lives down there near Greenville? Where are they going to go for care if you got an employee that lives there? Baptist Health charges $78,000 for a knee replacement, and they have the #1 quality scores for that. Deaconess charges $37,000. By the way, they did 780 knee replacements. Baptist Health did 90. Would you rather go somewhere where they do 780 or 90? I think they're pretty good at it if they do that many. Ohio County Hospital did that. There were no quality records. St. Vincent did that for $78,000. So those prices are close. Methodist Hospital, there was no info available. And then Owensboro Health Regional was $73,000. Good quality and so forth. But right here, if your employee had their way, where would you want them to go? And does your employee know that right now? Do they know where to go? Probably not. If they're using the insurance carrier's website, that's not set up to help you. It's set up to help them. So that's the place based on pretty good quality scores and a lot of procedures. They do more knee replacements than anybody up there. So how do we get that employee to go there? We're going to talk to you about that in a minute. One more, diagnostic colonoscopy. I'm going to go a little bit faster. 110 down there for $4,000. Ohio County Hospital, no info. 60 are done up there at St. Vincent. Methodist did about 80 for $25.50. And right there in your town, Owensboro Health. Good quality. And again, they did 140. So they did almost about close to as many as anybody. That's where you want to go. How are we getting that employee to know that? It's important, guys. And by the way, if you got people over 50 like me who hadn't gotten their colonoscopy done yet, I know y'all thought I was 35, but I'm turning 53 on September 26th, so please send me a card or a present. I hadn't got it done yet, but if it's free, right? Because that was part of the Affordable Care Act. Well, it ain't free. Free to the employee, but not to the employer. We got a client at the Gasparilla Hotel, $20,000 for colonoscopy we've seen. So carrier complicity. The Bucas know these deals, yet they stand by and passively pay $40,000 for one gallbladder, $135,000 for another. With your money, it's a problem. What have we bought? Healthcare the way we buy groceries. That's what we're going to offer you today as a way to do it. So we have access to Center Medicare services and commercial databases, cost procedure, what Medicare pays, what hospitals bills out. There's a nurse advocate to help the employee through the process, and we identify quality, cost-effective providers. But your plan design's got to reward the employee for making good decisions, and we're going to talk about that in a minute. But here's how it works. You got nurses and a patient advocacy team. They call in, and again, I'm going to keep beating this to death. In order to engage employees, your plan design's got to reward good decisions. We're going to talk about that in a second. How do I get them to Owensboro Health to get the colonoscopy? How do I do that? I'm going to show you in a second. Now, you got a PPO, you probably got some quality control issues. Whoever your BUCA is, how do you even know where the physicians fall? All of them are in the network, but what's important is how do we get the person, the employee, to go to physician B over physician I? Physician I is Dr. Hodad, hands of death and destruction. How do we get them to B? How do they even know how they are, if they're any good or not? So here's an example of knee replacement. This is St. Petersburg, Florida. We do a lot of work in Florida. There were 60 doctors that did knee replacements. There were 14 that did at least 50 or more a year. That was our cut. We want people doing 50 or more a year because if they're good at it, they're probably less expensive. Remember, price doesn't equal quality in healthcare. And they're good at it, and their quality's good because they do it all the time. Then we looked at the quality outcomes, readmit rates, and so forth, and the cost of implants. 4 fell out of the funnel. What are the chances of your employees picking those 4? I mean, that's a daunting task. Also, this particular doctor had 4.47 deaths. I'm not real sure how half a person dies, but anyway, that was the mortality rate that particular doctor had. When you want to know that before you get cut open, and my dad was an OBGYN, I told y'all, for 40 years in Macon, Georgia. And there was a doctor, that OBGYN, that was always at the golf course. I worked at the golf course, and they were always there. And I said, Dad, how come Dr. Stahl is always at the golf course and you're not? And he was a solo practice OBGYN. My dad had 4 partners. And I said, how's he always here? He said, well, son, his C-section rate's 50% and mine's 15. I think I want to know that for my wife, Missy, gets cut open 50% of the time. 15% was my father's average. That's about, was at that time was the national average. Wouldn't you want to know that up front? And then when we look at the hospitals, I protected the hospitals here, but if you look, would you rather go to the hospital did 538 knee replacements for that price of 55 or one for 161? All right, active management solution 2, data is available. Got to get in the hands of the consumer. Nurse navigators provide the guidance as we talked about, and use cash pricing whenever available. Plan designs have got to incentivize better decisions. So let's look at this cash. We often, when employees call into our cost and quality partner, they almost always, for any elective or pre-served procedure, try to get the cash price. This is a hospital in Florida that charges $37,500 for a vaginal birth. That's the cash price we were able to negotiate up front. $6,500, $7,500 now. Cash is king, and the hospitals will take your cash gladly, and we're real successful at that. If you worked with a Buca, $37,500 with a 50% discount, $18,000, $19,000. So again, in order to engage employees, the plan design's got to reward good decisions. Here's an example of what we would do. If Jonathan calls in and says, hey, I don't care that you said go see Dr. Schuessler, I'm going to go see Dr. Burgess, then his plan pays like it always paid. But if Jonathan goes and sees Dr. Schuessler, then maybe he doesn't have a copay, maybe he doesn't have a deductible. A lot of our plans don't have deductibles. That's what you do with this program. And I'm going to talk to you about another company. You heard DeSoto mention they use it. This is Gasparilla Inn. It's a hotel down in Florida. It's on the case study. I'm going to let y'all watch this real quick and listen to the benefits champion that this hotel hired because of all the money they saved to help members also above and beyond.
The inn itself is, the people are kind and the people actually care about each other, and they go out of their way to make you feel welcome as an employee, as a guest.
You know, with the benefits that the inn has brought forward to us, especially with healthcare, has been, you know, a welcome change from what was before and what I've seen in other companies as well.
The fact that everything is so hidden in healthcare across the board, I mean, the hospitals are the same way. How much does it cost? Nothing in America is sold that way other than healthcare.
Being here for 25 years at the inn, we've seen many different insurance programs come through. So when they decided to go self-insured, I didn't really know what that meant exactly and how that was going to go for us. For the last 4 years and coming to understand the insurance, absolutely. I hope we can keep it forever. It seems to work out well for both the employee and the company.
It certainly has. Yeah, I think it does align with our core values, being that we're, you know, family owned and we operate as a family.
Coming here and becoming a part of the family and receiving this type of offer meant so much to me.
We went and found and deconstructed the whole system and found the best components and brought 16 plus solutions together and seamlessly integrated them into this fair cost health plan that we've created. All of these years, the savings is probably around 1.6 million, somewhere in that range. Whether we eliminate the middle, we're going direct. That's how you save. It's direct to employer contracting.
Your benefits coordinator, in our case it's Liz, who's great, and she's always extremely helpful.
Having someone that you can call any moment of the day and say, hey, I have this issue, help me.
I am here and available to them 24 hours a day, even on the weekends, and to guide them if they have any questions about where to go, who to see, how to handle their plan.
Being that everything's transparent, there's a clear line of communication.
We can help redirect people to good care at good pricing.
We have a partnership with a local radiological facility, and because of the rates that they have agreed to, our members pay absolutely nothing.
How much money have I saved? Maybe a little over $5,000. For me and my family, that means a down payment for a home.
We're saving probably between $5,000 and $10,000 a year as a family. No, that's the difference between a few mortgage payments or college savings for my son.
Try to get the employees to understand it's a collective thing. Something we bought, you go use it or don't use it. It's our health care. If we all approach it correctly, we all have to pay less money out.
So the end deploy we call a benefits champion because of all the money they save. By the way, I messed that up. The savings was 1.8 million if you viewed fully insured going to self-funded over 3 years. But if we had self-funded with a BUCA, that savings is $3.8 billion. So if they had self-funded with a BUCA, it would have killed them. It would have hurt them bad. So these things can be achieved. And the benefits champion there, we get into that later up when we come to Kentucky. Significant position. Our school district client is deployed a benefits champion. It works, and we've got the person to help train them and so forth. It's a great, Liz is a rock star. She does a great job. So billing errors. Let's cover that real quick. Medical bill review. All right, so out of the gate, I'm not going to play this video, but this video was shot in 2010. It's 10 years old, and what it talks
when
about
I got a look at these hospital bills, I couldn't believe what Purple Gloves. Waltzman, and she helps people cull through all of these crazy charges, and she has all sorts of examples. I got to tell you, Cindy, this is one of my favorite ones. This is just like a little alcohol prep swab. We've all had these. How much did a hospital charge for these ones?
$23 a piece.
$23 for this little tiny piece of cotton.
And on one bill, there were 44 of them. Becomes very expensive.
Oh my goodness. But this isn't even the craziest thing you've ever seen. Tell me about one of your crazier charges.
Well, recently I had somebody that was charged for 41 IV bags when she went to the ER for a 2-hour visit.
Oh yes, you heard that right. A woman went to the emergency room with a migraine headache, and they gave her 1 bag of saline, and then they charged her for 41 bags of saline to the tune of $4,182. Now, the really crazy thing about this is that her insurance company actually paid this bill. They didn't even question it. So why did her insurance company pay for this when it was obviously wrong?
There's not many people working at these companies anymore, and they're very busy, and usually any kind of bill that's under $100,000, they don't look at the detail.
So they just write a check.
They just write a check.
All right, let's talk about this for a minute. And I can tell you from personal experience, my wife, when she had a laparoscopic appendectomy, you're going to see the bill in a minute. Let's be crystal clear. In October of 15, our country switched from ICD-10 codes to ICD-10 codes. So let me be clear about this with hospitals. 17,000 codes to 140,000. What a great idea. How'd that work out for you? Not well. So when we look at this, the U.S. General Accounting Office estimates that there are overcharges on 99% of all hospital bills. Again, guys, I don't blame the hospitals at all. It's just complicated. Equifax performed a national study. They found 97% were wrong. Services never provided, inaccurate quality of services, bundling, unbundling. When something happens 97% of the time, though, I don't know, folks. You tell me. But we've got to change it. So would you pay this bill? You and I went to dinner, and it was $1,033. Then we got the itemized bill, it was $180. The problem is all the bills that the insurance companies are reviewing are a summary bill. They don't get the itemized detail behind it. That's a big problem. So let me show you as an example. This is my wife's bill from August 6, 2016. Everything in yellow on that bill is wrong, and I'm going to cover it. Here the itemized bill, the page 2 of it, it was $29,984 for a laparoscopic appendectomy. I'm going to cover that in a minute. Remember, the bills that your insurance company or your third-party administrator are paying are based on a uniform bill. There's no itemized bills. There's not enough people working there to study these. It took us 3 weeks to get our itemized bill from the hospital, and we finally did. Everything in yellow is wrong. The way a hospital works and surgeries are done, they're billed out in 15-minute increments. My wife was in the hospital for 1 hour, so the charge for the OR was $56.54. No problem with that. But then we got charged for a urine qualitative. That's an early pregnancy test to make sure she wasn't pregnant. It's only $204. Could have gone to a community pharmacy and gotten it for $8. And then we got charged for oxygen and a premium stapler, $1,360 to staple her back. The problem is all that is built in and necessary integral to the OR. You can't unbundle and charge twice, and that's what was happening here. Some more mistakes I'm not going to cover, not as many, but a few. My favorite is we got charged for an observation room we never were in, $957. I don't know if we have a view of a dumpster or downtown Atlanta, but we never were in it. So that was a bill. It should have been $19,000. So it was almost $11,000 of savings that are done there. And again, all these codes, it makes it extremely complicated. Very difficult. And by the way, remember when I said healthcare had broken, it was made this way? Healthcare hasn't evolved. Look at what a bill for a childbirth was in 1943. We made it more complicated, folks, and we've got a computer in the hands of a grandma, 95 years old. Unbelievable. One more example. This is a hip replacement, $227,000 for a hip replacement. There were 16 titanium screws used for 97 grand. I don't think you can buy those at Ace Hardware, just for the record. But it was $97,000. We got the itemized bill for our client. There were only 4 screws used. The client saved $55,000. So it's a problem. The itemized bills are never saved. Would you ever pay that restaurant bill without looking at the itemized bill, putting your credit card down, then you get a summary bill? It's the exact opposite in this world. So under most of these arrangements, a lot of these contracts the BUCAs have won't allow you to do it. Review your hospital bills, but you can do a compliant medical bill review, and we can show you how. And we think you got to break that link between the networks and the hospitals and reintroduce fiduciary oversight and have all the claims reviewed again. And it's a big deal for the hospitals too, because some of their Medicare subsidies and things they get, the bills need to come out of there right also. So it's a good win-win for everybody here. But again, 17,000, 140,000 codes is a problem. That's how much you could save. Normally a health plan spends 60 to 70% of their whole spend is on facilities. That's the kind of money you could save. Non-disruptive, high impact, pretty simple stuff. All right, traditional PPO discount game. Let's get into defined benefit pricing. Our system today is passively managed, and it pays discounts. So hospitals, doctors, everybody get together and discuss, this is what we charge, and here's the price, and the insurance company gives a discount off of it. When you buy a car, you have Kelly's Blue Book. You do what we call bottom-up pricing because you have the price, and if the dealer's here and you're here, the dealer's going to talk to the manager, they're going to come down, and you're going to meet in the middle. This is all predetermined by the insurance company. You got no say in that. They're already doing it for you. And nobody ever asked discount off of what? That's what I often say. What's your favorite store to shop at? Amazon. Well, Jonathan, I got a deal for you. I know people at Amazon. I can get you 50% off at Amazon the rest of your life. One stipulation. You can't see the bill. Would you take that deal? And since I can't talk to any of y'all, the answer is always no. Why are we doing this in our health plans across America? Discount off of what? There's no correlation. And if PPO is the answer, how come the costs have gone up 4 times? The cost of goods and services across America the last 50 years when Medicare came out have gone up 8 times. Healthcare has gone up 274 times since then. So PPO discounts to the rescue's longest article in the history of Time magazine. A discount off an item that doesn't cost much really ain't worth anything, just like sales when you go to stores. So I got to go fast here. So here's the CT scan without contrast at a major hospital system. Hospital bill charge was that. Hospital costs, we have access to the data, was $45 at this particular hospital, filed with Center Medicare. Medicare pays $175, about almost 4 times what it cost. And then the national average your insurance companies have negotiated on your behalf are here. But when we dug in, we're seeing that at $26, $28, and we're at $300 to $450 per scan. So it's a real problem. And I got to be quick here, but if you look, this is the length of stays and days going up over a 10-year period. This is all hospital inpatient stays in Florida the last 10 years. On the right is the charges relative to Medicare that the commercial insurance companies have done. That's a 100% increase, folks. Medicare went up 11.2%. And what's interesting, they talked to you about these. Remember we said about these trend increases? Where's the advances in medical technology here where the average stay went from 3.93 days to 4.3? I don't understand that. It's a real problem. So there is no such thing as trend, as we said earlier. So we think you, the employer, should use your purchasing power. Go talk to hospitals. Go talk to physicians. We can show you how to do that. That's what you should do. It's what CalPERS did in 2011. California Public Employees Retirement System, one of the largest health plans in America. They went out and saw hip and knee replacements were killing them. $30,000 to $300,000 worth of cost. They went to 49 hospitals and said, or all hospitals said, we're going to pay you $30,000 for every hip and knee, and we'll send all the employees to you. 49 hospitals said, sign me up. And the other ones, over the course of the year, all lowered and matched their prices. You don't have to be CalPERS. There's 1.3 million lives in that plan. You don't have to be that. We've been successful for other companies doing this. Create your own network. Make it yours. Use your position in the community. Have safe harbor relationships with a hospital or two that we can work with, that we can weaponize the plan and send them there when the care is the best, that we'll work with them together. And direct contracting. We do a lot of that all the time. You heard it, we're going direct, eliminate the middles. You heard that theme in the videos. And then you can do it on imaging lab and other services. And there is no out-of-network. The employees of all these companies, you saw they go anywhere they want in America. And you're not paying $18 to $21 per employee per month access fees for these discounts that I don't really know what they do. And here's just an example. This is a fractured radius on the top. It's a fractured humerus on the bottom. That was the bill charges from the hospitals. That's what the BUCA would have paid. That's what we paid in working directly with the hospital. So if you want to talk about discounts, how about 89%? That was the Gasparilla and two of their employees. And so here's the truth about these contracts. I'll let y'all read it. I got to scoot. Doesn't have to be like this, folks. Doesn't have to be like this. All right, pharmaceutical shell game. I got to go fast here. We're going to call it RX optimization. It's a shell game. It's a black box. And this is how it works. There's a lot of money changing hands from the employer and the employee to get the drugs down here. And a lot of those Fortune 500 companies in that red box earlier are all in that mix. Unregulated, big abuse going on. This is Humira, the number one advertised drug in 2016. Everybody talks about research and development. That's where all the money goes. It goes to marketing, folks. That's where it goes. $3 billion's gone to the political class. RX used to make 8%. It's approaching 25 to 30. The average cost of Avastin, I hope none of y'all have to use that for cancer. Duke Medical charges $22,000. The average cost is $6,000 for the dosage. That's out of North Carolina stats. When's the last time you got a rebate? Why are we focused on rebates? How do you know it all got paid? And those dollars should come to you, not enrich someone else. And we think there's a lot of ways we can help you. And we always have a pharmacy consultant work with folks. And again, I showed y'all this earlier, and I'm just going to put names of the companies out there real quick. I got to move in the interest of time. All right, and then real quick, the 5 buckets of savings. You got to move away from a traditional PBM and do a pass-through. Eliminate spread pricing. We're going to talk about in a minute what that means. And go preferred, non-preferred pharmacies if possible. And what I mean by that is you charge less for a community pharmacy or a grocery store, Costco, Walmart. Just like you do in and out of network with your health plan, do it with your pharmacy. Our clients charge $15 less for preferred pharmacies versus non-preferred. But the good news is all the non-preferred pharmacies in the cartel are available to you. Just going to pay more. Funny how everybody goes to the ones that are $15 less. That's the savings you can get per 1,000 there. And we use there's the hotel, the Gasparilla Inn. We have a pharmacy that delivers twice daily to the hotel in HIPAA compliant bags. They don't even have to leave the hotel to get their drugs. That's what a community pharmacy can do for you. What is spread pricing? That's what the PBM allows. Let's focus on the top on Aclavir, $12.25. Pharmacy, the community pharmacy gets paid $2.25 to dispense that drug. That's it. That ain't gonna cover the labels or the bottles or anything. Patient pays $10, but they billed you for $17.97. That's the spread. And it's happening all over. Also, specialty drug savings. I think you all know that. Tons of savings. It could be way more than that. A lot of solutions there. Eliminate dumb drugs. Do Exes and Movo. Get rid of those drugs. There's 80 therapeutic equivalents. Don't have them on your plan and your formularies. And lastly, no mail order, guys. That's the biggest game going on. We don't do mail order. It's retail refill only and at the community or preferred pharmacy, a grocery store, Costco, Walmart. And that'll save you about $86 a script minimum. So the results are here. And that's about what we get 2025. So here's an example of a 600 life company with 1,200 belly buttons. Their cost was $135 per member per month, that benchmark we talked about. If we got them to the national average at 100, we could save them that. We got them to the fair cost average, that's how much they could save. 600 employees, not big, not a huge company. All right, lastly, lack of information and data. I got to go really quick. I'm sorry. And hey, guys, Kate, y'all stop me if I need to or whatever and tell me or just let me know. Data. You got to get good data. It's a big part of your budget is healthcare. How can you manage it without it? You can't manage what you can't measure. So we're talking about demystifying data. A lot of these programs the BUCAs have are more like Yellow Pages. We need to be working with Google. That's what we provide our clients. So real quick, this is one of our data analysts that we work with that helps us on all our fair cost clients. He covers about 32,000 members. And what we learned, and y'all know this, is about the top 10% of your members account for 73% of your costs. Many of you have probably seen that from a report. But what are you doing with the report and how are you fixing it? I'm going to show you what we do. Bottom 75 and the bottom 50. All right. So how do you influence it? You got to track these 27 chronic conditions and stratify them and rank them based on the risk. And again, we're going to talk about this in a minute and what we're doing. Here's some of the diseases tracked. Here's a case study. This is DeSoto Memorial Hospital again. 2 years of BUCA data, we identified 66 participants that had, I'm going to show y'all the categories we stratified in. 66, 2 years of data. 3 months on the fair cost health plan from January of 19 till April of 19. 31 more people were identified in 3 months, folks. That meant they had to have a claim, had to have a diagnosis code attached to be identified. This hospital doesn't hire and fire. They're static. They're not growing. They're staying the size they are. 31 more people. And here were the categories we broke them into. Lifestyle program, less than 5 claims. Disease management, again, these are identified by codes in the medical claims filing, 5 to 10, and then 19 chronic over 10. That's what we're able to do, and that's what's important. So we identify them in the 19 chronic patients. They get 24/7, 365 Bluetooth-enabled devices, glucometers. At the hospital, the diabetics have their glucose, their glucometer done 3 times a day. It's sent in, and if they aren't getting it done, these people are on them worse than any debt collector you've ever seen. And then at the end of the week, all of those clients that go to the direct primary care doctor, Dr. Gross, he gets a fax of their readouts. That's called integrated coordinated care. And again, how do we do it? There's no middles. It's all direct communication. All right. We also did the opioid study. We had a problem in 18 when we looked at opioids, a year on direct primary care, no more opioid problem at the hospital. And then there's a granular look at the data. Here's a large cancer claim review. There was a $206,000 claim. The service quantity, the amount of units used was 700. In order to take 700 units of this cancer chemo, you had to weigh 2,000 pounds. Big mistake, caught it, saved the client a lot of money. All right, bonus round real quick. I'm almost there. Because we got time, this is not an opportunity, but well, it is an opportunity, but not one of the big 6. Utilization management, disease management, and case management. What is that? That's the group when your calls come in and Jonathan has to get pre-certed for a knee replacement. That call comes in a utilization management company. And they also can offer disease management, case management. Quick story. Our school district client had a $3.2 million heart transplant. $3.2 million heart transplant 5 months ago. After the discounts, it was 2.2 million. Wow, what a bargain. Their stop loss is $900,000. So they forked out 900 grand. That is the first we heard of the heart transplant. In our model, that call would have come into the utilization management company to be pre-certed. I'd have gotten an email. The client got an email, all HIPAA protected, HIPAA officers. The cost and quality company get an email. The third-party administrator get an email, and the network development partner get an email. And everyone gets the hands on deck. Had we had it under our watch and not under a BUCA, we could have gotten that claim done for $184,000. That's what I'm talking about. This is a significant part of a health plan. And here's how it works. I don't have the time, but you can see the detail. This is what's supposed to be happening, but right now there is no utilization management being done in most of these BUCA insurer-built health plans. Again, that's the employer journey. So in summary, as you may survive, we've chosen to take a different path. Active management, you can too. And again, you can't hire a broker. You need a population health manager. That's what we do. And you got to use good data. And I think we've shown that at several examples here today of how important that data is in getting good data. And a lot of the data we're getting when it comes from the insurer built plans, not good data. Taking it forward, build employer built versus insurer built. Do you know what your benchmark costs are? If you don't, go find out. We see you on September 30th. You can tell us about it. Employers all over the country are doing this, guys. Mount Everest is once unclimbable. There's a litter problem. It's being done. We've done it with 4 clients. The mitigators are doing it all over the country. It is possible. All it takes is good advice and a little courage. So let us Uber your health plan before it gets Kodak. A little humor. And thanks for your time. It's time for a revolutionary approach. Hope and luck is not a strategy. And there's our contact information. Thank y'all so much.
Carl, thank you very much. A lot of great information. We certainly appreciate it. Certainly a different perspective there. So thank you so much for your time.
Thank you. Any questions or no time for that?
Yeah, I'll just take just a quick minute here to see if anybody wants to send any questions through chat. If not, folks are free to drop off, and we'll close the meeting.